So today we will discuss about the antiarrhythmic drugs, especially in case of the human beings mainly, and also these drugs can be used in the dog practice is concerned. So the antiarrhythmic drugs are the one which used to prevent or treat irregularities in cardiac rhythm, means the beats of the heart or the force of the contraction, etc. Whenever there is arrhythmia, then these drugs can be used. So what is a cardiac arrhythmia? Means it is the abnormality of the number one, it is the heart rate, then especially in the regularity in the heartbeat, then conduction of the cardiac impulses, then filling up of the ventricles by the auricles, then also the relationship in myocardial contractility. So these are the key points. So there is the difference in the heart rate and also in the beats, and the conductions of the cardiac impulses are important, and filling up of the ventricles by and also by the auricles, and the relationship in the myocardial contractility. So these are the factors which influence the cardiac arrhythmia, and the factors included are the in which this cardiac arrhythmia will be present means, number one, many myocardial diseases including the myocardial infarction, the central nervous system diseases, the renal failure, then wherever there is a hypoxia, then ischemia, then infarction of the cardiac muscles, and also certain cardiotoxic substances do cause the cardiac arrhythmia, and the adrenal or thyroid diseases, there is hyperthyroidism or hypothyroidism, and also the renin-angiotensin mechanism. If it is having some defects, definitely there will be the cardiac arrhythmia will be there. Then in certain CNS diseases also, then the cardiac problem will be there. Then excessive sensitivity to autonomic regulators, especially the adrenaline, noradrenaline release, etc. Then also there is whenever there is pheochromocytoma, a cancer of the adrenaline secreting glands, and there is a mechanical trauma which is caused to the heart may also cause the cardiac arrhythmia, and also in electrocution etc. Whenever there is a shock, then there will be severe cardiac arrhythmia, and changes in serum pH and also the electrolyte balance. So in this condition there is arrhythmia will be there, and excessive stretching up of the cardiac tissue is also another concern. And this is the generation of the different wave, especially in this particular chart you can see that the SA node, so atrial node is located here, and it will contribute to this part of the electrocardiogram, whereas the AV node, SA node, AV node do have the interconnection, and you can see that it is having the wave pattern like this, especially the electrical conducting system. So the impulsion conduction mechanism is from the SA node, then it will goes to the atrium, then AV node, then Purkinje fibers, and the ventricles. So this is the typical electrocardiographic result. That's the P wave, then this is the Q wave, this wave is the Q wave, R and S, and this is the T wave. So all these are referring. So the ECG pattern is combined of all these different electrical currents are concerned, though these waves are magnified here. So this is the pattern how a electrocardiographic pulse will be seen, and the mechanism of arrhythmias are many more. So the number one is disturbance in the impulse generation. So the impulse need to be generated in SA node and need to be conducted to the further part of the tissues. So there is a disturbance in impulse generation itself. Then the abnormal atomicity of the SA node. So there is it is also caused due to the alteration in the phase 4 of the depolarization. Then certain times the vagus stimulation or beta adrenoceptor blocking drugs slow the pacemaker. Then acceleration of pacemaker by hypokalemia or beta adrenoceptor stimulants. So this is the another thing. And apart from this one, there is enhanced atomicity in later pacemaker, and also the spontaneous rhythm which is taken by quiescent parts of the heart, and also the ectopic heart, means outside the regular location the heart will be there. So this is a congenital abnormality, and site of the heart initiating a latent impulse is also seen. Then the disturbances in impulse conduction is another criteria in which the antiarrhythmic drugs may be useful. So this may result from the block, especially the nodal block or bundle branch block. This is called as bundle branch block. And re-entry of the circus movement and echo beats, especially of the heart, is also seen. And the re-entry in which one impulse re-enters and excites the areas of the heart more than once without the need of the new impulse to be generated. So single impulses is generating multiple contractions. So this is caused due to the imbalance of the conductive velocity or refractoriness in the cardiac tissue. And some forms of the re-entry are functional re-entry and anatomical re-entry. Especially yesterday we have discussed that the Wolff-Parkinson-White syndrome, because this is re-entry of the electric current in the heart for the second beat without the generation of a new impulse. And here the pattern of the electric conductivity is there. So here the conductivity pattern is like this. From the Purkinje fibers it is going up, and there is a refractory area, because maybe in milliseconds or microseconds, so it will be there, especially in this particular cardiac this thing. Especially so there is a damaged area may be present in case of the heart, which stops the conduction of the retrograde passage of impulses. Here you can see that impulse is not passed through this particular damage. So usually the cardiac conduction is unidirectional. It is always unidirectional. Then there is a refractory area, just the impulse is passed. Then here you can see that the Purkinje fibers, then the impulse is also run to the ventricles and the atrium, etc. So it will be in the round pattern. So this is the schematic representation of the functionally defined re-entry circuit at Purkinje fibers and also in the ventricular junction. So here also Purkinje fibers, if there is a what you call as the damaginal area, then it will come here. There will be a retrograde passage of the impulses. Then it will re-entry. The second impulse will re-entry whenever there is a damaged area. Of course, whenever there is a damaged area, then there is chance that bidirectional block, means here this is a unidirectional block, this is a bidirectional block, and the retrograde passage of the impulse is not possible, so that the cardiac conduction is hamper totally. And this is anterograde impulse block, because the myocardial infarction is located. This is normal flow, so it is going by bidirectional. It is a diagrammatic representation of the generation of a re-entrant rhythm by a damaged area of the myocardium. So this is actually the damaged area of the myocardium, and whenever there is the anterograde impulse is blocked, means the impulse which is flowing freely from this area to here, it is blocked here. Whereas this is called as the circus movement. The pulse which is generated here, it is going to re-enter and it is doing a circus here. That is, it is called as the circus movement. Actually this is in the opposite direction to that of the normal impulse flow. So this is called as the circus movement. And antiarrhythmic anatomical re-entry, that's the Wolff-Parkinson-White syndrome is there. That means whenever you can see that the pulse is going to generated, then it will come here in the atrium, then the SA node, the AV node, then descending down to the ventricles. Like this it is a pattern. And the conduction block will be there. So 3 degree of severity of the AV block node are: number 1, the first degree AV block. So whenever a patient is having the cardiac attack or myocardial infarction, it's called as. So whenever this an area is blocked with a small blood clot, then what happens is at that time the blood supply to that particular part of the heart muscle is stopped. So it starts a necrosis type of the reaction, and this causes the angina, means is sodium channel blockers, and the action of this drug is changing the slope of phase 0, that means the first phase, and it can abolish tachyarrhythmia caused by recent re-entry of the circuit, reverse entry or re-entry of the circuit. Especially the beta blockers decrease heart rate, and conduction velocity. They can indirectly alter potassium and calcium, that's the conductance. Whereas the third category is the potassium channel blockers. What these drugs are going to do is they are going to increase action potential duration or effective refractory period, which is also shortened as ERP. Then the another mechanism is they delay the cardiac repolarization and inhibit re-entry of the tachycardia. So the potassium channels blockers are important agents, whereas the calcium channel blockers, because for the contraction of the heart, calcium ions are very, very important. Hence, slowing up of the calcium channel or blocking the particular channel will slow the rate of rise in pace of the SA node, and the decreased conduction velocity in the SA node and AV node both will be seen, especially in such type of the channel blockers, the calcium channel blockers. So there are, if we have learnt about the 4 categories: sodium channel blockers, then beta blockers, then potassium channel blockers, and also the calcium channel blockers. So coming to the class 1A drugs, then the quinidine. Please remember the drug, even though it's one of the oldest drug, quinidine or cinchona alkaloids. So these are obtained from the cinchona plant, and these drugs Syncona, as they were used once upon a time as anti-malarial drugs. So side effect of that drug is used here as the medicinal property. So this quinidine, which is obtained from Syncona plant, will block or open inactivated sodium channel during the first phase of the action potential. Then these also block potassium channels, not up to the extent of the potassium channel blockers, but they will block to some extent, and the negative inotropic effect is also brought by this agent, and to some extent they are also inducing anti-muscarinic effect. Then the increased duration of action potential and also the refractory period of the atrium and ventricles will also be increased. So this is a diagram showing the rate of rise in phase 0, that is the conduction velocity. So here the drug used is the quinidine, which is a class 1A drug, and also the procainamide. They are going to act in this particular thing, and these drugs make the slope more horizontal like this. So initially this will be the place when there is no drug, then it is shifted to right, means the Vmax of the cardiac action potential will always be altered, and they prolong the muscle action potential. Because of this thing, the slope of this particular wave, which is vertical in nature, becomes the horizontal, or they decrease the slope of the phase 4 spontaneous depolarization due to initiated by the SA node, and the decrease in enhanced normal automaticity will also be noticed. So what happens when we administer quinidine to a patient suffering from the cardiac disorders? There is prolonged PR interval and the QT interval, and also prolonged PR interval and widening up of the QRS complex, especially in the ECG, electrocardiogram. Then the pharmacokinetics of this drug, especially quinidine, it is well absorbed orally. Then the sulfate salt is, quinidine sulfate is absorbed more rapidly than the gluconate salt. So varieties of these salts are available. Then it has high plasma protein binding ability, and it is due to the plasma proteins. So this drug, the quinidine, is metabolized in the liver, and the active metabolite is also be there, and it is produced. Then 20% is excreted unchanged in the urine, especially the metabolic pattern, and usually given as low release formulation. And IM, if you want to administer IM, it is very, very painful, whereas IV is marked hypotension. So you can give IV, the drug also can be given IV, but there is a lot of pain at the site of injection. Just like in case of veterinary practice, the ethics of the production of the medicine is not followed, because whenever we give the injection of the oxytetracycline, the animal will have a lot of pain and discomfort, and this causes the uncomfortness to the animal, and of course the manufacturers has to think into this direction, and they need to make the drug less irritable. And of course the IV, fast IV or slow IV, whatever it may be, it causes the marked hypotension. Maybe the reasons are different. So what are all the clinical uses of the quinidine? especially this is used in the treatment of, so quinidine, it is bitter in taste, it is used in the treatment of supraventricular arrhythmia associated with anomalous conduction in Wolff Parkinson White syndrome. Especially in this particular syndrome, it is used as the line of treatment. And the contraindications of the quinidine, it is complete AV block or intraventricular conduction may be detected sometimes. Then also the myasthenia gravis, means it is also called as the Amitabh Bachchan disease, in which the antibodies are developed against the cholinergic receptors. And hepatic impairment will also be the one of the side effects are concerned, especially of the quinidine. Then the adverse effects, especially when it has got many adverse effects, and unless we are scheduled to a very proper dose, then it becomes toxic. So the number one is adverse effect is the cardiac effect. Then due to the anti-muscarinic effect, so the especially this is the atriofibrillar may precipitate the ventricular tachycardia, and sometimes it may cause the death of the patient who is suffering from this this is taking from this particular drug is concerned. And there is increase in the duration of QRS complex, AV block, then also acceleration of the ventricular tachycardia will be seen. Then cardiac standstill, it's also known as asystole in patients with sick sinus syndrome, means the sinus is not acting properly, then syncope may also happen. Then the cardiac adverse effects are the overdosage, depression, hypertension, then lethargy, seizures. The syncosine is also going to cause the headache, dizziness, tinnitus or ringing sound in the feeling up of the ringing sound, especially in the ears, and ultimately it may lead to the deafness. Then hypersensitivity reactions also in rare cases. Apart from this one, it is not indicated in the patients with hepatitis. Thrombocytopenia means the thrombocytes are reduced to the great extent. And apart from this one, the diarrhea, nausea, vomiting, all these clinical signs will be seen. And the drug interactions, since this is a long-term treatment, we should also give certain importance to the drug, especially the displacement from the tissue binding. So this may also happen. So one need to be very careful, especially while administering these particular drugs. Then apart from this one, decreasing digoxin renal clearance, then enhances the negative inotropic mechanism and the hypotensive effects of the beta adrenoceptor antagonist, and also the calcium antagonists like the verapamil and other drugs which are also the antiarrhythmic drugs. Then the next drug is the procainamide. So it is acting very similar to that of the quinidine, but it is less hypotensive. So whereas the quinidine is having lot of hypotensive activity, especially in the case of the elderly patients. So it is less anti-muscarinic in action, especially the procainamide. And the procainamide is having less cardiac toxicity action and completely absorbed after oral administration. This drug, especially procainamide, it is totally absorbed from the administration and can be given safely by any route of the administration. Like this quinidine and other thing, this is not having the pain at the site of the injection. So it can be given as IM or IV. and this drug is metabolized in liver and give active metabolite. Then this active metabolite has the class 3 activity, as we have discussed earlier, class 3 type of the arrhythmic activity. Then eliminated through the kidney, most effective in ventricular type arrhythmias, and it is the second drug of choice after lidocaine. Lidocaine is a local anesthetic which blocks the sodium conduction, especially in the increasing phase of the action potential generation, the lidocaine. And the ventricle arrhythmia is also treated with this particular drug. So this effective in case of atrial fibrillation due to the Wolff-Parkinson-White syndrome. So the overdose, especially procranial causes widening up of the QRS complex, junctional tachycardia, interventricular conduction defect will be the adverse effect. And on the heart, it's also going to cause the inotrophism, especially in higher quantity, that is going to cause the cardiac block. Then the GIT adverse effects are the nausea, diarrhea, and Tarside D pointers, a syndrome. Then the hypotension is also caused. So here you can see the adverse effect of this drug are the prolonged QT interval, then the QRS complex is widened. It is not so what you call as the discrete or thin. Coming to the class 1B antiarrhythmic drugs are sodium channel blockers, and these sodium channel blocker, they decrease the duration of action potential and shorten the refractory period. So refractory period is a period in which the heart is quiescent for a fraction of a second, and this includes the lidocaine, mexiletine, tocanidine, and phenytoin, and afredine. All these are the classes 1B examples. So to repeat again, it is lidocaine, then mexilinide, then tocanidine, then phenytoin, then also afredine. So these are the drugs which come under the class 1B. And the lidocaine, it shortens the action potential by the shortening the repolarization mechanism, and also effective in case of the ventricular arrhythmias, means arrhythmias originated from the ventricles. So class 1B drugs, they shorten the phase 3 repolarization and they decrease the duration of the action of the action potential. So the duration of the action potential. So usually this is called as the QRS complex, etc. So but it increases the duration of the action potential. So here the action potential will be generated, and the resting membrane potential, especially in the most of the cardiac muscle fiber, is minus 85 millivolts. Then it is going to be increased to zero, then it starts declining, whereas this is the phase 3 of the arrhythmia. So coming to the kinetic pattern, it is very well absorbed orally, then only 3% of the drug reach the general circulation, and these drugs, especially class 1B, are the given IV route only and excreted via kidneys, and half-life is about 2 hours. Then the therapeutic use of this drug, especially class 1B antiarrhythmic drugs, so these are the first drug of choice in the treatment of the ventricular arrhythmia. First drug of the choice. Then also in case of acute myocardial infarction, these are all the good drugs. Then the digitalis toxicity, yes, the digitalis, purpurea and other things, especially the cardiac glycosides, they are very commonly used, and whenever there is an increased dose or accidental intake of the drug in more quantity, then it may end up with the result of the digitalis toxicity. So it may cause the digitalis toxicity. And apart from this one, the anesthesia may also be caused. So lignocaine is a local anesthetic, but it may be caused. Then open heart surgery also, it may be used as one of the antiarrhythmic drugs. Then the adverse effects of these drugs are classified into very different categories. The number one is neurological effects, especially, and because of such neurological effect, they are contraindicated in epileptic patients. Then the arrhythmics are uncommon, and especially the side effects, whereas the hypotension is one of the important side effect of these drugs. And another drug called as the mexlatin, so it is effective orally only, so half-life is 8 to 20 hours. Then used in chronic treatment of ventricular arrhythmia. So we have to diagnose the arrhythmias very properly, maybe the use of the ECG, then give a specific drug for treating that of the ventricular arrhythmias. So these drugs will not act on the normal heart, only in case of the diseased heart the drugs will work, because there are active cells will be present. And this is effective in relieving the chronic pain due to the diabetic neuropathy and the nerve injury. Especially in case of the diabetic neuropathy, the patients suffer from the continuous and intermittent pains because of, especially the nerve endings, they will cause a lot of pain, and the regular, what you call as the non-steroidal anti-inflammatory agents or the corticosteroids, they are not so effective in relieving the pain of the cardiac origin, because of which is causing the diabetic neuropathy and the nerve injury. Then the adverse effects of these drugs are the neurological side effects are seen. Then it is contraindicated in bradycardia, means decreased heart rate, the AV conduction problem, defects of this AV conduction, then also another condition known as the hypotension, then also the hepatic failure or myocardial failures, and in all these conditions it is not indicated. And class 1C is most potent sodium channel blockers and decreases the rate of the rise of the action potential. Sodium channel blockers. So what are all the sodium channel blockers? Which includes flecainide, then profafenone, then moricizine, ticainide, then indecanide. So these are the drugs which are belonging to class 1C antiarrhythmic agents. Then the flecainide is not effective on the duration of acting potential and also the resting membrane potential. So the ability, it has got the ability to depress the conduction of velocity of his Purkinje system, and this is approved for refractory ventricular arrhythmias and also has pro-arrhythmic activity itself. So frecanide is also having the pro-arrhythmic effect. So one need to give attention to these side effects also. Then class 1 HC drugs, as usual, the resting membrane potential is minus 85 volt. It will be increased to 0 volt, and the slope of this particular graph will be increased, means the effective refractive period will be increased. Then another drug is known as the propafenone. Propafenone has a weak beta blocking effect, then used to maintain the sinus rhythm in case of the patients with supraventricular arrhythmias and atrial fibrillation. So the adverse effects of the propafenone are the metallic taste and constipation. So what is a metallic taste? Anybody knows? That's the metallic taste means if you consume a tablet of the metronidazole, which is a drug very commonly used in the traveler's diarrhea or the diarrhea of anaerobic microorganisms, then it causes a side effect like the metallic taste, means all the foods consumed will be bitter in taste, like that a feeling will come, and also the mouth will be dry and there will be constipation. So similar side effects are seen in the toxicity of propafenone. So compare between class 1A, B and C drugs as with respect to sodium channel, then also sodium channel blockade. So in case of the sodium channel blockade, the class 1C drugs are going to have more action when compared to the class 1A and the class 1B. That means it is having more and more the cardiac sodium channel blocker mechanism. So the class 1A examples, once again please remember that it is in the class 1A, is quinidine is the classical agent, whereas the class 1B is the lidocaine, and it has a what you call as the weak sodium channel blockade, and the increasing the ERP is the class 1A is having the less activity compared to the class 1C, and compared to the class 1B it is lower. So the treatment, then the class 2 antiarrhythmic drugs, so these are called as the beta adrenergic blockers. So the mechanism of action of the beta adrenergic blockers, it is already very dull, and a specific receptor will be bound by the beta adrenergic blocker and it is going to be blocked. So negative ionotropic and chronotropic action means the cardiac rate and force of the contraction will be reduced by the class 2 antiarrhythmic drugs, and these prolonged AV conduction and cause the delay, and these diminish the phase 4 depolarization and suppress the automaticity of the ectopic focus. So the uses of this drug is for the treatment of increased sympathetic activity induced arrhythmias such as stress. So whenever you are under the stress or do the exercise etc., the heart rate will be increased, and exercise induced arrhythmia, sometimes the exercise, sudden and abrupt exercises will induce arrhythmias, so that should not be done. Whereas the atrial flutters and fibrillations, also this drug can be used, and also the AV nodal tachycardia, that's increased cardiac rate due to the problem in a AV node, and reduced mortality in post myocardial infarctions of the patient. Then another use of these beta adrenergic blockers are the protection against sudden cardiac failures. So it will be done. And the classical example is the propranolol is a non-selective beta adrenergic blocker, and it was proved to reduce the incidence of sudden arrhythmic death after myocardial infarction. So that's the first line of the drug which is administered to patients which are suffering from the cardiac fibrillation. And the metoprolol is another beta blocking agent and reduce the risk of the bronchospasms, because the beta 2 type of the receptors are both they are present on the cardiac muscles and the bronchi. So bronchospasms are also one of the possibility when you administer a blocker, beta blocker. So these are not seen, and one of the agent very commonly used is esomolol. Is a very short acting beta 1 adrenergic blocker that is used by the intravenous route in case of the acute arrhythmias occurring during the surgery or emergencies. So what happens whenever there is a surgery, then due to the surgical maneuvers will cause the acute arrhythmia, and at that time you can use the esomolol, especially a beta 2 blocker. Class 3 potassium channel blockers, and these drugs prolong the duration of action potential and the RP or refractory period, and the use of this drug is in case of the supraventricular and ventricular tachyarrhythmias. So here you can see that class 3 drugs prolonged phase 3, this is phase 0, phase 1, phase 2 and phase 3 repolarization without altering the phase 0. That's the first phase, that is the rising phase, is not at all affected, whereas these are going to prolong the phase 3 duration, especially the refractory period. Then class 3 antiarrhythmic drugs are also called as the potassium blockers. So these prolong the phase 3 repolarization without altering the phase 0 of the initiation or upstroke or resting membrane potentials. So the potassium blockers prolong both the duration of action potential and also the ERP, and their mechanism of action is still not so clear, but it is thought that they block potassium channels. So in the figure also you can see that class 3 drugs, especially potassium channels blockers, so they are going to block the potassium channel, that's why the repolarization will be stopped. Then class 3 is also, there are examples like sotalol, then amiodarone, then ibutylide. So these are all the classical examples of the class 3 antiarrhythmic drugs. So class 3 antiarrhythmic drugs are associated with Wolff-Parkinson syndrome, wherein with the ventricular arrhythmias, especially the ventricular fibrillation or tachycardias, may also be seen. Yes, it is also used in case of supraventricular tachycardia. Then amiodarone use is limited due to its wide range of the side effects. Then sotalol, it's also called as Sotacor. It prolongs the duration of the action potential, and the another thing, that's the refractoriness. In all cardiac tissues, especially the cetalol, suppress the phase 4 of the spontaneous depolarization and possibly producing severe sinus bradycardia. So the another drug, that is the ibutylide, is used in case of the atrial fibrillation or flutter, and it is used as the IV agent, but may lead to another problem, that's the torcedo day pointers, one of the common side effect, and only drug in class 3 that possesses pure potassium blocking agent. The sotalol is a pure potassium channel blocker. Then amiodarone, or it's also known as cordarone. So amiodarone antiarrhythmic effect is complex in it is consisting of all the effects class 1, 2 and 3 and 4 actions, but it predominantly affect the potassium channel blocker, just like sotalol. It slows the cardiac conduction, and this works as a calcium channel blocker and a weak beta adrenergic blocker, and inhibition of activated sodium channel